the three organisations, the South Yorkshire CLAHRC, South Yorkshire CLRN and the Yorkshire and Humber RDS, welcome to this event. You'll be hearing more about the various organisations from their leads, but I know that all three organisations are deeply committed to patient and public involvement.
The three big organisations, the RDS, the CLRN and the CLAHRC, are working together in South Yorkshire, having come across different areas across the country, saying that they're having problems working together, bringing these three organisations together. I think what we have in South Yorkshire is a unique model.
Very proud to be here today, having spent 8 years looking at patient and public involvement. I do not think there's another locality in the country that could put on a meeting like the one that we've got today.
The big aim today was to show the world that patient and public involvement is alive and well and kicking in and around South Yorkshire specifically. It also shows the range of research that is being carried out in the locality, from clinical research all the way through to the research into the development of services.
The key benefit of strong PPI is having that patient perspective. It's actually an additional perspective, and I believe if you have the researcher's perspective as well as the patient's perspective together, then it adds value, and it means that the research projects are stronger, are better, are higher quality, and their results are more likely to lead to impact and to change.
We're going to be telling you a little bit about one of our core principles, something that we believe in South Yorkshire, which is what we call co-production. And it's about actually working with people to improve the service, to improve the interventions that we provide. And the CLAHRC is about taking the evidence and changing the way we provide services, the way we deliver services, and the way we care for ourselves as the public, and the way we care for our patients and carers as practitioners. So we're not just about doing applied research, we're about what we call knowledge mobilisation, taking the knowledge into the practice and into the world of South Yorkshire.
I think the longer I've worked in the NHS, I've realised we deliver services, we develop services as clinicians and think we know it all, and we've come unstuck a lot because we're not actually always developing services and systems that actually work for the patient. And I think we need to listen to their voice and actually understand how it feels from their perspective.
Through PPI and CRAG and all the other things, it's given me an insight into what research we've got coming, how we've come forward today, how we're allowed to see inside these allowed doors that we were never allowed to see in before. And now we can actually approach the consultants and the professors and all these people. We can talk to them on a one-to-one basis, which we could never do before. We had respect for them, or so we thought it was respect. It was sort of a reverence, but it wasn't reciprocated back. Now we have all of that.
I've got an increasingly progressive neurological condition, and I want to be an active partner in what happens to me. And I was so horrified by the way that you become a condition with a number. I wanted to be the real person, and this was one way of helping other folks become involved.
I think it really helps to have patients and public involved, because really they're the centre and they bring the experience of the disease to the research involved.
Quite often the focus of patients and the public are very different to those of the researchers, and it is a job for the RDS to try and manage that relationship. It's not always an easy relationship, and it's a learning curve on both sides, but it also is something that's worthwhile and will lead to more meaningful research.
We found that the lay panel has been an important facet for the bone BRU. They've become part of the research team. We think they feel comfortable now coming into the unit, working with us. It's been very rewarding for the bone BRU staff to see the enthusiasm and the commitment shown by the panel members, and to see the group mature as well and gain confidence. And they've had a valuable input into several aspects of the research process: study design and feasibility, recruitment and retention, and also in communicating our ideas out to the public.
What we have done is use our patient expert panel to do some patient satisfaction questionnaires within our inpatient unit, which has been extremely valuable because they've picked up things that patients may not have actually told a professional about in terms of the insights into the service that they've been receiving. So that's been added value, and we've been able to actually make changes as a result of that.
I'm going to illustrate our particular approach to PPI, which isn't really about PPI, it's more around the co-production that CLAHRC has as a central core theme. And I'm in a privileged position of being a nurse by background, but working in this team called User-Centred Healthcare Design. These are a bunch of designers, and they are interested in not only making beautiful objects, but they're also making beautiful services. And so we think there's a real kind of strength of using design thinking in health to really bring about sort of changes fundamentally to how we deliver services to patients. If you go to a designer and say, so how do you do PPI in your work? They don't understand what you're talking about. Because for designers, the client is the centre of everything they do anyway. It's always been that way. So for them, trying to work with NHS, for this is still kind of emergent and still coming out. It's quite interesting to see how they kind of respond to these things. The experience-based design approach is a series of making change within the NHS, but it's making change based on staff and patient experience. And the experience is so key. It's more than consultation, it's about involvement, it's about recognising that the real people with knowledge in the NHS are the patients.
My name's Tina Simpson, and I'm a Consumer Liaison Officer for the Trent Local Children's Research Network. We work extremely hard to ensure that patient and public involvement is at the forefront of every study and every researcher's mind. My role is to engage with young people, children and their families, and to make sure that they're involved in studies and study design and protocols, and that they're able to comment on literature and a whole host of things. So I run the Young Persons Advisory Group, where we have 12 members from ages 8 up to 19 who come along on a monthly basis, and they are taught the different elements of research so that they can embark on their own mini research project, young people's perceptions of clinical trials.
So far we've done critical reading, research and critical appraisal skills, and searching and reviewing the literature, and in the next meeting we're going to do research aims and questions. And I enjoy our group discussions that we have because we get to say what we think about what we've learnt throughout the day.
Through the Young Persons Advisory Group, we are ensuring that they are helping researchers to identify the topics, prioritise, commissioning, design research, managing the research, undertaking the research, analysing, evaluating and disseminating the results. And we're ensuring that within our region that we are involving young people in all of these aspects.
Since I've started attending focus group and young persons group, I feel that we are listened. Before, obviously I was always in that hospital and I didn't really know that there was anywhere that were actually listening, but yeah, we are listened to.
Hi, I'm Sheena, and I've got a condition called cerebral palsy, which was caused by brain hemorrhage, which happened when I was 5 years old, and I'm part of the Quality of Life focus group. The group was originally just designed for the parents of children with cerebral palsy, but me and my sister went along, and it's really interesting because I get my point of view across to them, and one parent even said that it's as if I'm telling them what their child might not be able to tell them. I'm the one that has to take the medication and live with the condition, so who better to ask? Hopefully they're taking that on board, and hopefully I can make a difference.
I'm giving advice to doctors on the condition which I have, and not all people are as well off as me. Some of them can't talk, some of them can't walk, and I think for me to be able to give my opinion and my point of view, I think hopefully they find it quite valuable.
I'd say your personal experience is worth a lot more than you think it is. You don't have to be the big influential voice. All you need to know about is yourself, and everyone does.
150,000 people in the UK that have a stroke every year. And of that 150,000, a third of them acquire this language disorder, aphasia.
I'm Rebecca Farmer and I'm a speech and language therapist by background. I specialise in stroke care, and one of the main projects that I lead is called CAHRC, which is a pilot study where we're looking at people using computer software in the long-term post-stroke to improve their word finding. Well, firstly, we set up a patient and public advisory group, and we got the patients involved by asking speech and language therapy colleagues for people who would be interested in that, and it snowballed from there. So people who became involved got other people involved. They had a go at using the computer program that we were testing out for us early on, and we observed them doing that, and that helped us to work out how we needed to introduce that program to other people with aphasia. And they also discussed with us what the sorts of things are that they would want us to know about using the computer. And we were able to take that information and use it to help form a topic guide for interviews that we're going to do with people on the project when they've got to the end of their time using the computer. What we really value in our project is the real experiences that people with communication difficulties have and what their opinions and their views are.
Sometimes it's very difficult for us to talk. However, the people who hear, then it's always good to take to us. And of course I speak half German as well, so sometimes it helps that all us together. You always speak only to yourself or your husband, and so it's always nice to have other people.
Well, of course, clearly it helps my wife Carol with her mixing with people. It gives my wife a chance to talk to other aphasia sufferers. It gives me as a carer to talk to other carers and share our problems. So it gives you confidence to be able to go forward. It gives the researchers a chance to see at first hand what the problems are. Not reading it from a textbook. It is actually there, being present at the meetings, that helps tremendously.
PPI is something that as clinical researchers we're very much expected to do now, and I wasn't sure how that would go with people who have communication difficulties, because obviously they're going to struggle with contributing to the project. And in actual fact, through using different activities and not just discussion, they've been able to contribute hugely actually to making our project much more closely related to the patient group that we're doing it for.
When I went to the meetings, I had problems of my speech, and eventually my speech has come on and on and on. And also, if I can get the questions, then I can say exactly what I think, which is nice for me as well.
In previous work I've done, I've found that having a member of the public sat in doesn't help that much actually, but the best way to go is actually to have people in a separate group so they can talk much more freely about their experiences, and so you can pick up from that the things that are relevant to your research.
The reason for coming to the event today is to hopefully stimulate other people into forming groups like this, because it is so rewarding.
I would like patients to be able to discuss with their multidisciplinary teams what they are going to do about their illness, and I think also that patients should remember that good health is the result of collaboration. We need more patient and public participation so that the word is spread throughout, and we need to make sure that it's implemented, not just, a tick box exercise.
From 16-year-olds to 60-plus-year-olds, they all are convinced that they want to put something back to help other people that will suffer from their problems in the future, but that their involvement will help to enhance the quality of the research that's being carried out.
I hope that we can continue to drive the agenda forward, but do that in a critical way, so that we can reflect on what works and what doesn't work, and we have kind of an open forum where we can discuss the barriers to public involvement, the reasons why it might not be so good, and obviously what is really good about public involvement. So that's hopefully, if we can take it forward in that kind of open dialogue, I think that's what I look forward to in the future.
I'm hoping that more people will, one, see the benefits from the point of view of the researcher, but also people who are service users. I think it's not all professional workers today. It's not all researchers. So I'd like people on the other side of the equation to want to take part and to feel they're valued.